When we look at treating the other symptoms of Alzheimer's disease, we're talking about treating mood, behavior, sleep, and even pain. Important in treating all of those is to recognize that there are other strategies or interventions that we can use that we refer to as non-pharmacological. In other words, not using medications to treat symptoms that we're seeing. Some basic rules of the road to remember are that we want to avoid fatigue in the person with Alzheimer's disease, that we need to create breaks throughout the day for them so that they can kind of recharge their batteries, restore themselves. If we keep them running full tilt all day, we're liable to see more confusion, more anxiety or agitation later in the day and into the evening. We want to create a predictable daily routine and minimize change as much as possible. They will function better and feel safer and more secure in an environment where they know what's happening and where things are. It's when you create change with things like traveling that you often see behaviors emerge as they try and reorient to even a place that they've been before, but maybe it's been a year since they were back east last summer. We often get panic calls on how agitated somebody has become and how confused they've become. We can't underscore how important it is to have that predictable routine and to realize whether they can or cannot handle the stress of travel. It doesn't mean that we can't introduce new activities or environments to them. It just means we have to do it sensitively. We want to be able to provide meaningful engagement to them. One, it keeps them from getting distracted with other behaviors. So much like kids, if they are bored, they create their own distraction, and we don't want to have negative kinds of distractions set in. Nor do we want to have depression or anger or resentment because they have nothing to look forward to. We want to make sure that when we recognize those early signs of illness, that we're getting them into the doctors early, not later, and that we try and use as much as possible the primary care physician's office rather than the emergency room, because that is a tremendously disruptive and anxiety-provoking, disorienting environment for somebody with Alzheimer's disease. We want to make sure that in our communication, in what's in the environment and the daily structure, that we're not giving them too much information, that we're not overloading them. So an example would be, remember, they need to be more concrete, they need simpler choices. We don't want to say, what do you want for dinner? We could have the chicken or the beef, but I've got some peas or vegetables that could be green beans or the baked beans. What do you think? It's going to overwhelm them. Too many choices that they can't hold on to, so we avoid that. Misleading stimuli we want to pay attention to if we are seeing behavioral changes that might include things like you reporting hallucinations. We need to pay attention to in what context are those being noted, because often it's things like mirrors or reflective surfaces, windows, shades that aren't pulled close or tight at night, and we're getting this kind of shimmering light through that can be misperceived by the person with Alzheimer's disease. Pictures in the environment, dolls, all kinds of things can be triggers for the person misperceiving something in the environment and being disturbed by it. So that's what we mean when we say avoiding misleading or overstimuli. Not giving too much verbal information, giving it at a level and a pace that they can understand, and watching what's in the environment. Not too much noise, not too many people, not too much disruption in the routine. And that means that one of the greatest challenges to you as the care provider is that you have to constantly adapt. You constantly have to modify the way you are approaching the person because they're not able to. We have to remember that this is a disease process going on in the brain. It's very easy to interpret it as willful behaviors, especially when we have a history of interacting with somebody a certain way. But they cannot change. So accepting where they are, adapting to where they are, changing your communication so that you help them feel safe and comfortable and promote a sense of interaction. And I think probably the biggest tip is to not challenge or correct statements that you're going to hear from the person with Alzheimer's disease, because we will hear statements that you will say are not true, that are false beliefs or delusions. When we look at treating mood features, obviously all the things that we just talked about in terms of creating meaningful activity, a daily schedule to look forward to, goes a long way to improving depression and reducing anxiety. But sometimes we need a little extra help over and above that, particularly if somebody is more suicidal or so depressed that they have no energy to bring towards trying activities or programs, for instance. So in that case, we use antidepressants. And mind you, when we say for mood, although they're antidepressants, most of them also address anxiety as well. The most common ones used are the ones from the class called SSRIs. You might recognize the older ones as Paxil and Prozac, for instance. We try and avoid those because they have negative side effects, A, in elderly people, and B, specifically in people with dementia. But the newer ones with sertraline, which is generic for Zoloft, citalopram, generic for Celexa, and escitalopram, generic for Lexapro, can be very, very effective. Start with a low dose and then you build up and maximize the dose before you can actually say that the medicine is not working. So start low, but go and maximize before trying something else. Sometimes we use other antidepressants based on the symptoms that we're seeing, or if we're clearly not seeing a response to the SSRIs or they have intolerance to those medications. In particular, one of the ones we might use is called Mirtazapine. We use that in particular if somebody is depressed, not eating well, and not sleeping well, because the primary side effects are it makes someone feel sleepy. We give it at night, and it also makes someone feel hungry. So if we're seeing weight loss that isn't responding to some of the strategies we're going to talk about in a few minutes, Mirtazapine can be a great tool in the toolbox. You may also hear of medications like venlafaxine or Effexor, bupropion or Wellbutrin, for instance. In general, we want to avoid the class of drugs called Benzodiazepines. These are medications you would recognize because they're all generic and they end in PAM, P-A-M. So Lorazepam, diazepam, temazepam. These would be drugs you would know as Valium or Ativan, for instance. These are medications that can have a higher risk of confusion and a higher risk of falls in the elderly in general, and again specifically in those with dementia. Tricyclics, these would be your amitriptyline or your nortriptyline or Elavil, for instance, have the same negative effects in people with dementia. And fluoxetine or paroxetine are again medications that are on lists not to be used as people age and in elderly population because they can cause more confusion. That would be your Paxil and your Prozac medications. When we look at treating behavior, our first step is always, have we done everything in terms of stress-free environment, consistency of daily routine, slowness, reassurance in communication, simplifying the communication, creating activity that engages them and makes them feel happy. That's our first approach with behaviors, but if separate from that we're still seeing an escalation, it's not responding, we can't distract them, we can't get off of it, The behaviors are happening more frequently, more severely. They're lasting longer. They have more punch to them, literally. So they are more verbally aggressive or more frankly paranoid, to the point that they won't even take medications or eat because they're afraid you're trying to poison them, for instance. Then we have to use medications to treat the behavioral symptoms. Here again, we may use, if somebody is not already on either the cholinesterase inhibitors or the memantine or the Namenda that we talked about, those cognitive medications, they can have a good effect on mild to moderate behavioral features as well as mood features. So we always want to make sure those are on board. Our second choice then would be to use the antidepressants. Why would we do that? Well, if we look at depression on one end of the continuum for mood and we look at anxiety on the other end, they're going to meet in the middle as behavioral manifestations. So if we think about negativity being associated with depression, I have low energy, there's nothing to look forward to. That can come out as cynicism, pessimism, negative context, nobody can do anything right, pointing the finger or accusing people all of the time. Anxiety can feel unsettling. It can make somebody feel edgy. We can see more easy irritability, for instance. And so that meeting in the middle as those sort of behavioral manifestations is exactly why we might use an antidepressant first. Cost is cheaper and the side effect profile is also better than using some of the higher levels. But if those avenues are not working, sometimes we do have to go then to what we call the atypical antipsychotics. That means the newer generation of psychotic medications that are out on the market that have sort of supplanted the older ones like Haldol or haloperidol. In this class, the more commonly used one is quetiapine or Seroquel, but we would also use risperidone or olanzapine, which would be a Zyprexa. The concerns with using the atypical antipsychotics is that number one is that they have a black box warning. You've probably seen the commercials on TV saying elderly people with dementia should not take these medications. They're all that we have to use with symptoms like paranoia or suspiciousness or hallucinations that are disturbing, because these are medications that get used for chronic conditions like schizophrenia or bipolar. So we use them, but we use them judiciously. So again, always what are we doing in terms of communication and environment? Have we addressed with lower classes of medication, but now we need to use the antipsychotics. We're going to start low, we're going to build up slowly, but we're going to build to a point where we get reduction of symptoms without the side effects. And again, just as we used seizure medications for mood, we may also use those on occasion for behavioral symptoms as well. When we look at sleep features, the most important strategy is what we call sleep hygiene. That means that we want to create as predictable a bedtime routine and ritual as we can, and on the other end, a predictable awake time in the morning. We want to make sure that we have low levels of lighting at night so that everything is about quieting, about getting darker, about getting ready for bed. In the morning, we want to have light. We want to have those curtains open. We want to sit out on the patio if we can and absorb 10 minutes of sun. If we're using these sort of strategies to help someone sleep and we're still having issues, then we want to try medications like trazodone, which actually is a mood medication, but its main effect is that it can cause sleepiness. So we can use anywhere from 50 to 200 milligrams of that and see if that helps improve sleep. Mirtazapine or Remeron is the antidepressant I mentioned earlier that has sedation or sleepiness as one of its side effects. Just over-the-counter melatonin is often an effective strategy, anywhere from 3 to 12 milligrams. So this is something you can try on your own and see if it helps your person sleep. And then from there we would use, if need be, the atypical antipsychotics, because they have sedation or sleepiness as one of their side effects as well. I should add in there that even sometimes using an antidepressant like citalopram can be effective, depending on what we hear. So if somebody tells me that the reason they're not able to fall asleep at night is because they can't shut their brain off, the real problem is that they're anxious. They're trying to hold on to too many things. They're worrying about what needs to get done tomorrow or what's going to happen tomorrow. So if I treat underlying anxiety, they're able to sleep at night. Again, as we saw with the medications for mood, we don't want to use the benzodiazepines. We don't want to use those Valiums and those Lorazepams or Ativans to help people sleep, because while they may help people fall asleep, they don't help them stay asleep. And when they wake up, they're more confused and more at risk for falls. We also don't want to use antihistamines or drugs that have PM in the formula, Excedrin PM, Tylenol PM. Those all contain diphenhydramine, which is your antihistamine. High risk for confusion and falls. One of the things I want to talk about next is the importance of treating pain in people with dementia. I can't stress enough how much untreated pain can be a source of behaviors, how pain can cause agitation and aggression and resistance to help with personal care. As somebody hurts and doesn't want to be moved in a given direction or way, and you're trying to help them. So treating underlying pain is important. If there's a source of chronic pain, we need to treat chronically, because remember, they can't tell us when it's feeling worse. So we definitely want to make sure that if there's chronic source of pain, we treat chronically, that we don't use pain medication as what we call a PRN or per need, because they can't remember that that's the system. So we don't treat as needed. One of the most effective pain strategies can be just routine acetaminophen, which is generic Tylenol, up to 3 grams or 3,000 milligrams a day. And that includes if for any reason your loved one has any kind of combination product. So that would be like your Vicodin, where you have a combination of an opioid and Tylenol. We don't want to exceed 3 grams total of Tylenol. Very effective for mild to moderate pain. I generally advise using even the extra strength Tylenol or acetaminophen, and starting with at least twice a day at bedtime, so that pain is not an issue as they sleep, and in the morning, because so many times it's that morning stiffness that's hard, and then as they get up and moving, they do better. If there are greater issues of pain, certainly then we have to use higher levels of medication, so opioids when appropriate for moderate to severe pain. And you want to work with your pain specialist to make sure that it's the lowest possible dose, but that you treat appropriately, because again, this affects quality of life. You'll notice that I say use other strategies as well. Let's not forget the psychological comfort that comes from things like topical analgesics. So if you have a sore joint, think about how that Bengay might feel as that heat kind of soaks in and bathes the joint. There's a lot of comfort from that. Using moist heat, using massage, these are all things that can be helpful. If it's a newer onset kind of condition, then even a course of physical therapy as an adjunct to pain management is advised.